All of you thank you. All of you are webcam off, so nobody can see you and nobody can see your name or anything like that. If you do have any technical difficulties, not much we can do except ask you to log out and then rejoin. Usually, like vast majority of the time, that solves the issue. We also do have closed captioning available, so you can activate that just going to the bottom of your Zoom tab, and there'll be an option to say show captions, and you can actually set the language as well. And we have it provided probably for the vast majority of you joining in English. We also have a certificate of attendance. We'll drop that once we do the Q&A session. We'll do a Zoom poll. We'll send out a feedback survey and a link that you can fill out. It's not an automatic thing. You give your email and a name, and it'll automatically generate one for you. So yeah, please learn more. Join us if you haven't already. With that, I will stop sharing. There we go. And I will happily welcome Emily Como, who is a psychiatry residency, part of the psychiatry residency program. I think you've just started, if I'm not mistaken. It's in you're associated with the Department of Psychiatry at Dalhousie University. You have Matt Vaughn, new communications manager for the Canadian AIDS Society. Hi, Matt. And then we also have Sheila Wildman, associate professor of law with the Schulich School of Law, and that's also at Dalhousie, and also a co-chair of the East Coast Prison Justice Society. So I'll turn my webcam off. I'll leave it to you folks, and then I'll pop back in when you're ready for the Q&A.
Okay. Thanks, Alex. And thanks everyone for joining, especially anyone who's otherwise has the day off today. Really appreciate you coming to learn with us. So like Alex said, we're presenting a paper today that was published last year called More of the Same but Worse Than Before. And it's based out of the Halifax Regional Municipality, or I'll just refer to as Halifax for most of the rest of the presentation. I also want to mention that Matthew Herder was another co-author on this paper, but he couldn't make it today. All right, so a bit of an overview. I want to briefly add to the land acknowledgement that Alex had done, and then we'll get into the legal framework, which Sheila will cover. Then Matt and I will go over the research study itself, our results, and get into a discussion and hopefully a Q&A. So we want to acknowledge that the land that this research took place on is the ancestral and unceded territory of the Mi'kmaq people. And the Mi'kmaq and Maliseet people first signed this Treaty of Peace and Friendship in 1725. Of course, we want to go beyond just acknowledging this land and strive for awareness and respect and understanding of the Indigenous people who have always called this land home. All right, Sheila.
Thanks, Emily. And I just wanted to also say thanks so much for the invitation to come and present this work. And the invitation really from Emily and Matt and the other Matt to join the project in the first place, which, yeah, I was just really honored to be part of. So I was asked to set the stage in terms of the legal context, and it's Emily and Matt who are going to give you more of the goods, like the real central value of this project, which was the evidence that came from the interviews and talking with folks who were directly affected by this coming together of we sometimes call, I think too easily, the opioid crisis, but a whole set of challenges around substance use and of course COVID-19. But I wanted to start with the human context. I'm really grateful to Emily for putting that photo up with this background on the losses. So we're starting with the context of just, incredible loss. And I don't see who is all around the table here at this webinar, but I'm always, so mindful that we come together around having lost people who we care about. Many of us have come, have brushed up against real personal peril. And so these are topics that you sometimes lose that when you start with the the statistics and the law, but but it's also the enormity of the loss that we're starting with on this slide. So we've just given you a few stats from Canada. So recent stats on the number of deaths. So starting with between 2016 and March 2023. So it's rising up to almost 40,000 opioid toxicity deaths. And so that's at the center of the project that Emily and Matt and the Matts got started with, is those losses in the big picture. Then just moving to most recently, this is just, it's not slowing down. So this year, January to March 2023, so just the first part of this year, already nearly 2,000 deaths. That comes to 21 per day, 81% of which involving fentanyl. There's also some important data coming up around mixed substance use and the toxic supply. So the fact that almost 50% of opioid toxicity deaths in this last period have also involved a stimulant is really important to keep in mind. And that's something that came out recently in our own jurisdiction in Nova Scotia. There was comment on cocaine use also being, involved in some of the toxicity and overdose deaths. And so it just adds another element for us to be mindful of as we wrap our heads around what is happening. And then just to go back to the start of COVID-19, which is around the time when this project is really focusing. So what shifted, what changed with COVID-19? It started with reporting on, again, statistics. So the number of deaths going up in BC. Several jurisdictions reported higher rates of fatal overdoses and other harms as the pandemic got started. I see in Ontario, there was a 25% increase in suspected drug-related deaths between March and May 2020. In BC, it was in the first 8 months, they surpassed the total for all of the year before. So death rates going up, right, with COVID-19. And the why to that is partly what is motivating the study that we did. Certainly there's a whole set of hypotheses and work that's been coming out substantiating. So, the increasingly toxic, unregulated supply, lots of different barriers to access to harm reduction services, treatment. I'm just reading from something here from the Ontario Drug Policy Research Network, as well as the physical distancing requirements leading to more people using alone. Next slide. I think somebody, there we go. So that's the background of loss and the enormity of loss. But I want to turn to the legal framework. And the first thing we have to start with is criminalization. And the quote I pulled is actually, if you just Google this quote, you'll find a whole lot of people in a whole lot of contexts in different jurisdictions saying the same thing, that the war on drugs has failed. So criminalization, use of criminalization and incarceration as a response to substance use problems and certainly the kind of epidemic of death that we've seen has been a failure, and yet the war continues. And so that's the context really that we start with. So it's roundly recognized that criminalization is doing far more harm than good, but we have to add to our analysis lack of safe supply and all the barriers to safe supply, including legal barriers, as we think about how to unpick this problem. I just wanted to make mention of the sort of the flip side, or the other side of criminalization. So once you pass through criminalization into incarceration is what I'm thinking, that we feel even, can I say even more intensely, but with a different kind of intensity, the problems that we're talking about here. So barriers to access to harm reduction and to safe supply are only compounded and intensified once one finds oneself in jail. As mentioned, I'm co-chair of East Coast Prison Justice, and I've just given a link to a paper, I think maybe when I first met you, Matt, I'm not sure. I think I met you before that, but it was the first thing certainly that we sat down and worked on writing. And I was looking at the date of it just earlier, and it's March 4th, 2020. It was just before the whole, COVID state of emergency came down. And that's when we published this thing that criticized lack of access to OAT therapy and other kinds of supports in jails. In Nova Scotia, we have a policy actually that is still in place, which says you can't start OAT treatment unless you've been on it in community already. That's, once you enter jail. So a whole host of things we could say there, but it's part of the package of criminalization and incarceration and the kind of just the intensification of harm that comes with that. So there have been some partial responses to the harms of criminalization, or to the recognition of the way that criminalization contributes to harm since COVID-19. And the next slide will give a sense of what those are. And I'm going to let Matt and Emily talk more about the claim that we're making, that it haven't been enough. And I think we can recognize, given the intensity of the continuing deaths, that these responses haven't been enough. So we start just as a little bit of background with some exemptions that were made under the Controlled Drugs and Substances Act in March of 2020, and these have recently been extended to 2026. So what were these exemptions? They allow pharmacists, as it says there on the slide, to renew and extend and transfer narcotic prescriptions. Doctors, physicians can verbally prescribe, and pharmacists can also deliver or designate someone to deliver medications to folks. So these were attempts to respond to the kinds of barriers that were arising during COVID-19 as pharmacy services were shutting down or slowing down, and people were having to social distance or stay at home and all of that. So these were partial measures. And again, I'm going to leave it to Emily and Matt to talk about how people responded to those in our study. BC also has more recently been granted an exemption by Health Canada, again under the same act, which amounts to partial decriminalization. It's effective, this exemption is effective again till 2026 or January of 2026. And it, under this, adults are not to be arrested or charged for possession of small amounts of certain specified substances. So opioids, that includes heroin, morphine, fentanyl, crack and powder cocaine, methamphetamines, and MDMA. So if one has 2.5 grams or less, one is not subject to arrest or criminal charges, and the drugs aren't seized. So that's the partial decriminalization piece coming out of BC. And from what I understand, the response is that this is one important move. Again, and it's positive, and it's to be recognized as important, but it also has its own serious limitations, the limit to 2.5 grams. So anything beyond that is still criminalized, and as I understand it, it's rare that drugs consumed by folks exist in that amount. Second, splitting and sharing drugs isn't covered, and that can amount to trafficking and a charge for that. That discourages people from using together potentially. And last, as I understand it, benzodiazepines aren't included, and that's a big limitation as well. So last thing I wanted to add goes to sort of future of legal stuff, and I don't want to dwell on this, but just to put a plug in for the PWUD litigation, which is has been started in the BC Supreme Court, as I understand it, which goes to decriminalization based on some charter arguments. And Martha Jackman, I've given a plug to an article which I really should have put in the book that this is published in, but you can find it on SSRN if you just Google this title, and you'll see a really neat argument on decriminalization of possession as a charter right and a constitutional imperative. So I'm going to just stop there now and turn it over to is it Emily?
Yeah.
Yes. There you go.
Is
Thanks,
it me?
Sheila.
I see the M, so I'm
Sorry, Matt. Turn it over to Matt. Sorry about that.
Is it me, Emily, or is it you?
It's you, I think.
It's
Okay.
you.
Go for it.
I can go ahead. Yeah, so just a little bit more background on the overdose epidemic that we've been dealing with. And there's a really cool paper that was published in the International Journal of Drug Policy in 2017 by Dan Ciccarone that describes kind of the three waves of the overdose epidemic. And there's actually a fourth wave, which Sheila talked about stimulants and polysubstance use. But the first wave was started with prescription opioids, and the second wave was ended up being heroin, more of a kind of a stronger opioid. And now we've seen a really big wave, a big increase in fentanyl. And so we're kind of in like a full circle where we're trying to go back to the prescription opioids so we can have a safe supply of drugs for people, because with synthetic drugs, you got underground chemists making drugs with precursors bought on the internet, and they just don't have very much chemistry background. And people are just really trying anything to make some money, and it's killing a lot of people. COVID-19 obviously interrupted a lot of harm reduction services, and addiction medicine services, and overdose events increased. So I can see that also being another wave of the overdose crisis. That could probably be, we're seeing more and more deaths. It was harder to get a lot of the precursors mailed in, so a lot of the drugs, the way that I always heard it, like before COVID, like a lot of the fentanyl that was being made was pretty smooth. You had a lot of like the same batches were being made, but then once the supply was interrupted, it was harder to get those precursors, and people were kind of just cutting it with whatever they could, using benzodiazepine, xylazine, and those are obviously are very harmful substances. And I think it's become a trend. Back in the day, they would cut drugs with caffeine and less harmful substances but more expensive, and now these precursors are very cheap and easy to obtain, but they're very harmful. And also with the COVID-19 pandemic, a lot of the stay-at-home orders caused people to use drugs alone. Thankfully, we've had, innovative services like the National Overdose Response Service to, call somebody, or, spotting somebody online. So people have adapted to try to keep people safe. I know I've used like many different services online to stay safe, and I'd give my address to somebody I would use. If I overdosed, they would have my address, they'd have contact number with somebody with naloxone that they could administer quicker. And I used to do that from someone in Seattle, so like there's quite a bit away, but then like these things actually are effective. And as the Health Canada exemptions were a great starting point, they're certainly not enough in terms of beating the overdose crisis. Next slide. So what is safe supply? And this is essentially, we talk about many different themes in this paper, but the main kind of theme is what is safe supply in Halifax. And this was the first qualitative paper in Halifax on safe supply. So, when we talk about safe supply, we use Capuit's definition, which was published in February 2019, and it's a legal and regulated supply of drugs with mind and body altering properties that were traditionally offered illegally. So, that could be cocaine, that could be heroin, that could be prescription drugs that weren't prescribed to you, a wide range of psychoactive substances. And safer supply, which is now, why we're here today, is, a new trend to start to give people a safe supply. And I was actually just watching a documentary last night, one in Vancouver, and Mark Tyndall was saying, like, it's not about the toxic, it's about what people have to do to get these toxic drugs that really causes a lot of the harms in their life, and then the toxic drugs are the icing on the cake. So we're at the point where we need to just give people drugs to keep them safe, and then they can get housing, and they can get employment, and they can start to live their life again. And I thought it was a really nice comment from him. And Mark is a big pioneer in safe supply. And as the federal government supports safe supply, they don't really have a plan for sustainable safe supply programs. Not that I'm aware of. They recently just raided Dolph, which was offering a compassion club, which is a non-medicalized safe supply where people buy their drugs on the dark web or buy their drugs from a supply, test them, and distribute them at a cheaper cost. And the federal government, to my knowledge, they always just said, okay, well, doctors can prescribe a safe supply if they want to, but that's just not a sustainable way to scale up programs. And I think people need more than just safe supply. They need wraparound care, they need wound care, they need HIV and hepatitis C care. People are dealing with all kinds of health and social issues that they need support with. So safe supply or safer supply versus OAT. And I always say safe supply is OAT 2.0 because it's still a very medicalized model. You still kind of got to go to the pharmacy every day. You got to go see your doctor every day. There's many benefits of safe supply that saves lives, but there are a lot of barriers to implementing them. And so I think a lot of doctors and there's this huge narrative, there's such a backlash on safe supply right now, around conservative ideology, just wanting to take away people's free drugs. But the evidence speaks for itself that safe supply isn't causing any of these deaths. It's caused by the toxic drugs. But a lot of the critics worry about diversion. There's this big narrative in BC right now that there's a lot of Dilaudids, and a lot of youth are using Dilaudids. But I know as a youth I used Dilaudids, so I don't think it was anything to do with safe supply. Youth use drugs, right? So I think it's just a tactic that that can be used to try to stop implementing these programs. And OAT just doesn't work for everybody. There's all kinds of different options. I've been on every type of OAT: methadone, buprenorphine, Sublocade, slow release oral morphine, safe supply, and I just haven't found one that worked for me. And so it's we need to start offering people the drugs that they need. And at least in BC now, they do offer different variations of fentanyl for people that are medicalized, but it's, from my understanding, it's still not meeting the needs of what's being made on the street. And I'll pass it to you, Emily.
All right. Thanks, Matt. So now I want to get into a little more of the Nova Scotia context to set up to tell you about our study. So the HRM, or really Halifax, Dartmouth area, it's almost 500,000 people who live here now. And there's no formal provincial government support for safe supply here. However, like I said, it's happening on this case by case basis through healthcare providers that can write prescriptions only. There's 2 safe injection sites in Nova Scotia. One of them is here in Halifax, and the other one's in Sydney, Cape Breton, called Refix, and then Pier 6. In HRM, there's multiple opioid agonist therapy clinics. There's one needle exchange called Mainline, and there's a withdrawal management unit. So like Matt had said, we're pretty proud to say it's the first qualitative study that took place on the topic of safe supply in Nova Scotia. And the time that these interviews took place was in 2020, right around the height of the pandemic. And it was published in, I'm just going to say PLOS1 journal, maybe PLOS, maybe PLOS. I'm not sure what people are calling this journal. Sorry about that. So our overall aim was to try to center the voices of people who use drugs, to try to inform ways forward. For example, with trying to model different versions of safe supply. So although it's in the local context, we're hoping that we can extrapolate this a little bit more broadly. And we divided it into a number of research questions. The first one is just trying to understand the experiences of people who use drugs, or specifically opioids, during the first year of the pandemic. And we tried to focus mostly on this. So there's 13 participants who are persons who used opioids, and then 6 healthcare providers. So we also interviewed these healthcare providers to try to understand their experiences in trying to provide care to people who use opioids during the pandemic. And then we just pretty clearly asked each participant, what are your thoughts on safe supply? Are you receiving safe supply? Have you heard of safe supply? What models are you receiving safe supply in? And that was the last one of our questions. We'll try and zip through the methods to get more into the meat of our study, the results. But basically, we recruited people on social media. We had posters. We used word of mouth. We did something called snowball sampling. So say I interviewed someone and they said, I have a friend who might be interested in participating. We would just direct them to email us. And then for healthcare providers, we asked, we just emailed people and seeing who was interested in taking part in the study. And we did try to get a diverse group to get a range of opinions. To be eligible for the study, you just had to be over 18, live in the HRM, and speak English. And then you either had to be using opioids or be working with people who do. This is the demographics of people who use drugs in our study. The average age was 40, and 85% were receiving income assistance. And this was around the time when CERB, or the Canadian Emergency Response Benefit, came out. So a number of people were receiving that. And the average time spent in Nova Scotia, in Halifax, was 17 years. Homelessness, or experiences of homelessness, was definitely overrepresented in our study. 85% of people were currently or previously homeless. Almost half were precariously housed at the time of the study, either in shelters or were placed in hotels during the early pandemic. And most people had said that they wanted to participate because they wanted to educate the public. And then the second most commonly cited reason for participation was our honorarium, which, fair enough. So the demographics of our healthcare providers: we had 2 attending staff physicians, 1 resident physician, a pharmacist, a nurse, and a community-based OAT staff member. And these are intentionally a little bit vague. We were trying to maintain confidentiality among all participants. And everyone agreed to being quoted when they participated in the study, so long as they weren't identifiable. So the interviews lasted on average 40 minutes, which I think is a pretty good amount of time. We were so grateful that people would spend that much time talking with us. The interviews were semi-structured. We had a separate interview guide for participants who used opioids versus healthcare providers. And they were flexible in the sense that if themes came up during the interviews that we found kept repeating or were really interesting, we would then modify the interview guides and incorporate those questions into later interviews. The analysis, I transcribed the interviews myself, which initially I thought would be a bit of a pain, but I'm actually very grateful for in retrospect. I think it was a good way to, re-listen to the interviews, get a little bit closer to the data. After that, I de-identified the interviews, and then as a team, we all came together, sorted them into themes, they were coded, and it was just this iterative process of trying to identify the most common themes that came up amongst the interviews, and we had separated them, that we kind of separated the healthcare provider themes. And we did this using Braun and Clark's thematic analysis. Something that came up in our review process was, how is this analysis different from grounded theory, which is quite popular? And really the difference is that we didn't try to come up with theories based on our results. We were more just presenting the clusters of themes and not trying to derive a theory based off that. We do want to add a disclaimer though, that of course, reading the transcripts and coding them, we're seeing and reading this through our own experiences and our own aspirations for this work. All right. So this is the main themes that came up. We'll try and focus mostly on the topics that have to do with safe supply for the purpose of this talk. And Matt, did you want to jump in?
Yeah, and so Emily and I are kind of going to bounce through these themes. Emily will read a quote, and then I'll kind of speak to, what I felt, what I felt that quote meant to that person. And, like I recruited a lot of the individuals for the study, so I was pretty close to a lot of them. But the main themes were, conceptions of safe supply, and honestly, there wasn't safe supply was very new at the time, and especially in Halifax, so a lot of people weren't too aware of this concept, so we thought that was interesting. There was barriers and facilitators of safe supply, federal government exemptions, the switch to telemedicine and helpful or missing services. And we'll probably not talk too much about those ones because they're not that related to kind of the safe supply, but we would like to highlight some of the services that people found really helpful during the pandemic. Halifax is in a dire housing crisis now. We have all kinds of encampments, and I think that's plays right into the overdose crisis and colonialism and just capitalism, and we're just seeing more and more of that, and it all goes hand in hand with people who use drugs and the health and social issues they are experiencing. And then this is kind of my favorite last theme, and it's a lot of people were panic drug buying, like it was a lot harder to get drugs, but there was, these big CERB checks. And so people, when they got their checks, they were buying a lot of drugs. Drugs went up in price. And ironically, once we started to have some more safe supply, they kind of went down a little bit. But for the most part, Halifax has been a prescription pill city, but now we're seeing a lot of fentanyl and other synthetic substances.
Okay, I'll start by reading the first quote, if that's all right, Matt.
Yep.
So this is a quote from an addiction medicine physician. On a broader system perspective, I don't have evidence that tells me what I'm doing, is referring to offering safe supply, is not going to cause harm for the greater population. Like, am I going to inadvertently shift the drug market here?
Yeah, and I feel like I know a lot of these physicians, But and I think for a long time, a lot of people were on the fence about, safe supply. Even a lot of the progressive OAT clinic, OAT physicians. But I think, we have great student doctors that are great advocates that do amazing work and that have changed a lot of minds. So, we even have now we have a MOSH safe supply program where there's actual funding to have so many people on safe supply. So like I think people are more, I think physicians are scared that if they prescribe a drug and somebody overdoses and dies for it, they're going to be accountable. But I think we have to look at it the other way around and say, well, if they don't prescribe that drug to that person and they go and they use that drug, then they should be just as accountable. So I think that speaks to a little bit about what this person is saying.
Yep, I agree. And something that came up, I don't have it written down here, but I think it was the same person that had said neither option feels good in terms of either prescribing safe supply or not prescribing safe supply, but had said that doing nothing feels worse. That one stuck with me. And another thing is that we were trying to get some diversity in opinions on safe supply in the people that we interviewed. And I think this next quote highlights that. Safe supply spread very rapidly without a lot of rigorous evidence behind its safety. I'm leery about being a safe supply provider without rigorous clinical trials backing the practice. It caught fire in Vancouver because it's a necessity and the only intervention that will save lives. I don't think that's the truth for the entirety of the country.
Yeah, and Emily, I think, I'll just briefly say, I think you spoke to it earlier, like this is just a stall tactic for physicians not providing safe supply. Like Vancouver is obviously a very unique place, but people use drugs all over the country, especially in big urban city centers, Halifax, Toronto, Vancouver, practically everywhere people use drugs, and so there's no reason not to provide a safe supply when all people are using is, dangerous synthetic drugs.
Yeah. Okay. The next quote is, I think safe supply is amazing because people like me and other women like me who are selling our bodies for drugs wouldn't have to sell much. You know what I mean?
Yeah, and I love this quote, and I think it speaks so well to kind of what I was speaking to earlier about like the harms people have to put themselves through just to get the drug, right? People experience a lot of trauma and a lot of traumatic events in their lives, and they just want to feel good, and using drugs does that, but they live in this cycle of um you know re-traumatizing themselves. And sex work is work, and I completely agree with that. But I feel like if women don't want to, if people, not just women, if anybody doesn't want to sell their body but they have to, they're stuck in survival sex work and they're doing it for drugs. If a doctor can prescribe them and they can pick that up for $5 out of the pharmacy, I think it saves so much harm for that person and gives them their life back.
Yeah. And I also wanted to highlight that under conceptions of safe supply, only one of the quotes we've included out of 4 is from someone who uses drugs. And that is an imbalance that we noted throughout the study, that healthcare providers had so much more to say on safe supply versus the people that it was could be directly affecting. And that just kind of made us take a step back and think of, okay, wow, it really is not the people with lived experience that are the ones at the table trying to decide where we go with this, where so many were actually just unfamiliar with what safe supply was in general. So that's why there's this imbalance in under conceptions of safe supply in terms of who we're quoting. The next quote is a good example of why some people didn't feel that OAT, like methadone or Suboxone, is kind of synonymous with safe supply. It's more just on a spectrum. So they said, that's what safe supply is really about, recognizing that some people cannot give up the needle and will not be able to, and it's not acceptable to ask them to. So what can we do to make that as safe as possible?
Yeah, and in Nova Scotia we have a really great I just noticed that from a pharmacist. So we have a really great brown bag program at about 300 pharmacies across Nova Scotia where you can go in and you can get long tips or short tips. You don't have to pay for them. You get cookers, water, all the using supplies, and you can do it in a non-judgmental way. And not all pharmacies are on board with it, but I think more are not. And it's right. Like people, I don't know how many times I went in and bought a bag and needles and said, oh, they're from my grandfather, and or just lied, or I'm a diabetic or whatever, right? And so like if you can just go in and do that in a non-stigmatizing way, you just feel so much better about yourself.
All right. Oops, sorry. So in the interest of time, I think if it's all right with you, Matt and Sheila, we'll focus on the topics of safe supply, try to get to touch on panic drug buying as a theme, but then move into a discussion. Okay, the next quote. This is under barriers and facilitators of safe supply. I guess first, the main barriers that came up among healthcare providers is fear of college repercussions, going against the grain in this very strict opioid deprescribing culture, inadequate education and professional programs about addiction or safe supply at all, burnout, trying to take on a really challenging topic when you're burnt out, political and moral issues that are tied to substance use, fear of causing harm by over prescribing that could lead to overdose or diversion. The next quote. Don't put this on the shoulders of doctors and say, now you must make this a medical thing. We've used drugs since the beginning of time and will always use drugs. Just decriminalize this already and try not to medicalize it. Drug use is real life, but it's also this taboo thing that's always been with us, and we just need to accept it and have some understanding.
Yeah, and I always say, you don't go to your doctor for a bottle of wine, so why would you go to your doctor for a line of cocaine? So, I think I love this quote, and I love that it's from an addiction medicine physician. And we really do need to decriminalize it and invest in health and social services, and provide the care to people that need it, and let people use drugs.
And the next quote really starts to touch on the main theme of stigma and discrimination that was everywhere in our study. So you could tell he was not a fan, he being the physician, was not a fan of anybody asking for anything. He said stuff like, do you really want a pill for every ill? He was belittling me. I said, could you please just talk to the pharmacist before you go off on me? He called the pharmacist and he made sure to say with extra emphasis that I was seeking extra meds.
Yeah, and like that's a common occurrence for people who use drugs, and that's one of the cons of the brown bag program. You never know if that pharmacist may call your physician. I do believe that a lot of these exemptions are giving pharmacists more power to renew prescriptions, renew narcotics, kind of you don't it's just kind of changing the way that we are practicing healthcare. And I think it could be a good thing, but I think a doctor who trains to work with people who use drugs and marginalized populations compared to pharmacists who are more trained to work with drugs and whatnot, I think people would be better off, seeing somebody who's going to be compassionate and caring towards them.
Okay. The last quote under this theme is, I'm sure a lot of my friends would still be here if we had a safe supply. I've lost so many friends due to this stuff. It's just insane.
Yeah, and I don't even think I can really say anything else to this. Like I'm 33 years old and I can't even count as the amount of people that I've lost in my life, and like I've overdosed probably 15 or 20 times since the pandemic, so it just shows the state of the crisis that we're in, and the lack of government support to do anything.
Okay. I'm just going to skip forward to the last theme of panic drug buying. This was a really interesting thing that came up. So I'll just read the first one here. People are straight up pulling out $2,000 and buying everything that they can because they can. People are forced into a situation so desperate that they're going to that purple fentanyl of unknown purity and source. It could even be carfentanil, and that really sucks about this pandemic. Everybody's got money and everybody's looking and everybody's getting money around the same time, and it's just a free for all.
Yeah, it's interesting. I remember I actually got caught with fentanyl back in 2017, and that's kind of when it started to make its way in Halifax, and it came through what we called shady 80s pressed oxy 80 pills. Um, but then you go 3 years down the road and now it's everywhere, so it's not being tricked into the drug supply. People are actually buying it for what it is. And that just shows you how drug trends change so frequently, and how we were typically a prescription pill city, and we could have, I think we could have curbed a lot of these deaths if we started to prescribe safe supply back in 2017, when people still wanted Dilaudid and they didn't want fentanyl and other synthetics.
Okay. And I just want to say, I think I speak for everyone on this call when I say thank you so much, Matt, for sharing your own experiences. It's definitely makes everything that we're talking about feel a lot more, I don't know, it feels very real and very personal. So I appreciate you sharing this with everyone. The
My
last quote,
pleasure.
the last quote is essentially it's somebody who's talking about how they experienced overdose during the pandemic, and that's not something that had happened until the pandemic, and they are placing blame essentially on this toxic drug supply. All right, I'm going to move us into the discussion.
Yeah, so and please, like, feel free to reach out and ask any questions. I'm an open book. Obviously people who use drugs face so many different challenges. Um, and they were all worsened by the pandemic. And I know I've lost a lot of people just since the pandemic. I've noticed a lot more overdoses. Um, the lack of services, or the closure of services, really kind of made people um you know use unsafely. But there have been innovative measures to help them use safely at home, but nothing is perfect. Not you want to always be using with someone with naloxone, and you don't just want one naloxone kit. Nowadays you need 2 or 3 naloxone kits. I overdosed on Saturday, and it took like 4 naloxone kits, and it's just like the dope right now is so strong. And I'm just going to share a little bit about my experience with our safe supply program, and I have the utmost respect for all the physicians that are doing the work, but I actually got kicked off of the safe supply program, and I was on 24 dilaudid 8s, 24 milligram dilaudid 24 8 milligram dilaudid 8 milligram 24 8 milligram dilaudids, 100 microgram fentanyl patch, 120 milligrams of Ritalin, and 3 milligrams of clonazepam. And I just never, like, it just didn't take the itch away from wanting to use, and I could inject them, and it just wasn't as strong. And I turned to, like, selling my drugs, and I'm a pretty honest person. So once I told them that, they told me, it wouldn't be forever, if I had to go back on it, which I may have to someday, that they'd be there for me. But it was a tough time. Like, that time, I overdosed on that. um I overdosed off of all that safe supply, and my excuse with my family, because they knew I was getting all these drugs, I was saying, "Oh, I'm not overdosing, so something's working." And then I overdosed, and it took like 8 vials of naloxone, and I was in Emerge all day, and it was like probably one of the worst overdoses ever. And I just remember them peeling the patch off me, and I was like, "Oh, this is gonna be horrible." And I couldn't get a hold of the doctors, and it made me really really sad, because like they put me on all these opioids. I felt like they should have been there. It was a long weekend. It was, I don't know, I think it was like Canada Day weekend or something. But that's why we need like really robust programs that are 24/7, and people can walk in and get their drugs, and just be seen by somebody, and it'll be taken care of, right? So, I think we have a lot to do everywhere, is not just in Halifax or Toronto or Vancouver, like in North America. We're in a huge crisis, and if we want to get out of it, we're not going to do it by prescribing. It's going to help, but we really need to look at non-medicalized models. We need to look at legalizing drugs. We need to look at investing in health and social services and housing complexes. So we really do need a complete change in the way that we do things for the most marginalized people.
Completely agree. And I think to bring it back to what we found in our work is that, like Matt's been saying, the services just aren't even coming close to meeting the needs of the population that they're trying to serve. However, I think a strength of what we did was to try to amplify those voices. One of the things that, in retrospect, I wish that we had asked about is how people identified, what's their gender, their ethnicity, because I think that could be important information in trying to shape the way that things go forward. A big thing that came up in terms of just, especially throughout the review process that we did, was what is safe supply? And it made us really question, what do we consider safe supply? Kaput and Matt was so helpful in this, but overall, we felt like the scope of substances, it was still unclear. Seeing it more on a continuum has been really helpful for me. The model of safe supply provision, most people in our study did not receive safe supply on this case-by-case basis. It was more daily dispense of OAT. So we didn't see a variety of models. But I think a big thing that came up was the conditions of accessibility, and what we heard from participants, I think, could shape the conditions that we can offer these services. Like Matt was just saying, does this need to be medicalized? For example, seeing it through intersectional terms, Like one of the women, someone who identified as a woman in our study, said that she didn't feel safe going to the safe injection site because it got moved to like really close to the men's shelter, and that didn't feel safe for her. And another thing is all this stigma and discrimination that participants describe, as, including in their interactions with the healthcare system. Then to them, it feels unsafe to access substances in that same relationship. So how to solve all the ambiguity about all these questions? We all think it's meaningful integration of people with lived experience on how to shape safe supply moving forward. I'm going to skip the discussion of the other themes. So we conclude that we need to ask ourselves, since doing nothing feels worse, how can we best support access to a non-tainted supply of substances to demonstrate equal respect for the lives, liberty, and security of people who use drugs? And I also want to say again, thanks to Matt Herder, who's involved in this work and supervised me throughout the project. Matt or Sheila, do you have anything to add?
No, I just want to thank the National Safer Supply Community of Practice for having us on, and highlighting some East Coast work, because I think a lot of safe supply work is focused in Toronto or Vancouver, so it's nice to get some geographical diversity.
Yeah, I'd echo that, thanks so much. I was looking at something in the chat from Richard Gold, which said that the number of deaths reminds him of the early AIDS epidemic. He said community action was very important in taking control of that situation and helping to drive more innovative and effective care. And Matt, you mentioned earlier the raid on the Dulf Compassion Club folks, and I can't help but think of just how much that works against the wisdom that's coming out of this study and out of, especially, your contributions, Matt, which, and all those contributions from the amazing insights that came out of the interviews, Emily, on what safety means to people. It means more than just get me to a doctor's office and give me a safe, substance. There's a whole lot more to safety that we're only touching on here, but I'm really glad to start the conversation with you guys.
Thank you to you all. We'll just take a pause, and what we'll do is we'll ask anybody who has any questions to pop them into the Q&A box. That's right at the bottom of the Zoom screen. What we'll also do right now is we will launch our poll. Here we go. So you'll get a little prompt on your screen that asks you just to fill out a couple of questions, where you're coming from, what you learned today. And then my colleague Robin as well has popped in a link to complete our survey, the little feedback survey, and also the link for the certificate of attendance if you should need one for any reason. So we'll just leave the poll open. That's totally fine. If anybody does have any questions that they want to pop them in the chat. Yeah, I would first thank you for the presentation and for, I think, your comments there, Sheila, and well, all of you actually have kind of alluded to, yeah, this real devastating thing that's happened with Dulf that would impact not just that community of like 43 or 45 people that were actually receiving like a safer supply through Dulf, but sort of like the community around it, but also other communities that are operating compassion clubs, either like, under the radar, that are probably pretty scared right now, or people who are thinking about doing it are probably kind of freaked out about whether that is something that they want to risk doing. So yeah, I think you really nailed it really on the head there. I was curious to know, because you had said that this was the first presentation. I was like just curious to know if you had done like any other knowledge translation stuff with this paper, or if you had like maybe like, I don't know, you had presented to your colleagues, Emily, or like maybe one of you went to a conference, or I'm like just curious if you had any other chances to do that, because I think you've all made that really good point of this is really one of the only studies that talks about safer supply in like an East Coast context. So yeah, I was just curious if that platform had been given to you in other spaces, in other ways.
Sorry, I think when we were chatting earlier, I'd
Mm.
said that I just hadn't done a webinar with the work
Oh,
before.
okay. I'm
But we
sorry.
did, no, that's okay. We did present it in, it was when the work had not, it wasn't yet published, but it was the
Okay.
Canadian Center on Substance Use and Addiction Conference. We
Okay.
put in a
Okay, yeah,
poster
yeah.
and it actually did an oral presentation for that.
Oh, cool. Okay.
Yeah. So
Okay, so first we've got the first webinar.
yes, the first
Okay.
webinar.
All right. Fair enough. Fair enough. Oh,
I
hi,
had
Rebecca.
can jump in because I can't type in the question and answer box.
Okay.
But you talked a lot about how the Halifax and Nova Scotia has always traditionally been seen as like a pill prescription based drug supply. And I have heard people say that they didn't feel that safer supply, that is the prescribing of dilaudid, fit Nova Scotia, the East Coast, in places where fentanyl wasn't present. But Matt, I just wanted to give you another opportunity to emphasize why it still may make sense to move people from unregulated dilaudid or hydromorphone supply to a regulated pharmaceutical prescribed or more regulated as opposed to prescribed, because it doesn't have to be prescribed, right? It could be compassion clubs and things like that. It doesn't have to be medicalized. But yeah.
Yeah, and I think we are seeing a lot more like I hate to say it, but I feel like there are a lot more Dilaudid coming from the West Coast. There definitely is some diversion happening. But that's typical with all drugs, right? And I feel like if the more you use fentanyl, um, you can use Dilaudid, you can use a couple a day and you'll be fine. Um, Once you start using fentanyl, you have to use it so frequent, your tolerance goes up, you get so much sicker. So I think if we can curb that in any way, not only will people, if you have a regulated supply, you know what's in it, you know the quality, you know the quantity, you're probably not going to overdose compared to, just some kind of synthetic substance. Um, yeah, I grew up using Dilaudid. Like I've been using Dilaudid for 20 years, but now they don't do nothing, right? So I feel like if people are going to use drugs and there's no way of stopping them or no way of changing their narrative on it, if we can give them that safe regulated supply, we can save a lot of lives quicker. And I think it's definitely like a Halifax thing, but I would say it's more of like an Atlantic region thing. I think drugs flow into Toronto and Vancouver and then kind of disperse out from there. So I think if we can curb it in places where people are diverting those meds already, and just like if you go to the doctor and you say, I'm using these drugs, can I get my own prescription? And the doctor says yes, I think that's where we need to kind of go.
Thanks, Matt. I just thinking about how it's easier to move somebody from unregulated hydromorphone supply to regulated hydromorphone compared to from unregulated fentanyl to regulated hydromorphone. But also that, yeah, like as you said, diversions existed always and forever, and people have been using hydromorphone in different ways for a long time. Yeah, but totally predates Safer Supply.
Yeah, and I think, prescription pills got a bad rap with Purdue, and Purdue does own Dilaudid, and so I think that's a big downfall for trying to implement a lot of these programs. But I think we got to start to change the way we think about that, and invest, don't give them all the money made from it. Invest in health and social services and affordable housing, and take some of the profits from these pharmaceutical companies and give it to the communities.
I'm wondering if anybody else in the Q&A box, there's no questions, but, and we are kind of technically running a few minutes overtime. So I want to just ask if there's any other questions in the room. Please put them in there or in the chat even. You can put them in the chat, we'll see them. If not, I'd like to just say thank you so much for coming and presenting. We've been emailing, I think, since the summer, and so I'm really happy that we made it happen before 2024 happened. So yeah, thank you so much to you three and to Matthew Herder as well, who was a big part of the project. What we'll do is we'll stop the recording. We'll upload that onto YouTube and onto our webpage in a couple of days, maybe tomorrow or Wednesday. We'll circulate that on our social media, in our Google group, and we'll be sure to highlight it in our upcoming newsletter, probably like the 1st or 2nd of December. Yeah, I don't see any final questions, so I think we're okay to end. So thank you so much, and yeah, we'll see you at our next events, which we have in the works and are going to announce pretty soon. So stay tuned for that.